Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHTC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. If you'll go to the first update, excuse me. So this is really interesting. ASTP just published what they're calling the 2024 Draft Fire Action Plan. There's some confusion about when comments are due. They have a blog piece that indicates November 25th, but the original announcement that I saw said November 2nd. And if you go into the plan itself, it says commenting is available ongoing. But we will take a look at it, and maybe there will be some further clarification on exactly when comments are due. But the idea here is that they want to try to support innovation through FHIR and also strengthen the consistent use of FHIR across HHS. So what they've done is they've split things into 6 areas that are listed on the slide. I'm not going to read all of them. And they've taken what they consider the more mature implementation guides that fall into those areas, and they have kind of a standard write-up where they provide certain pieces of information consistently about each of them to help provide context on how best to use those implementation guides. And so that's kind of the idea, is that they're saying these are all guides that you should consider using. Here's when it's appropriate. Here's where we think it's appropriate to use it. Here's the maturity level, and a few other things like that. So you can find some information in the blog piece, which is the first link. That's where it says November 25th deadline. And then the actual action plan is actually a series of web pages that start at that about page. That's the second link. Any questions, thoughts, comments there? All right, let's keep going then. So CMS has put out a proposed rule, which is essentially called the Affordable Care Act 2026 program parameters. Comments are due by November 12th. It includes a bunch of modifications and standard practices they'd like to impose on the marketplaces, on payers that go into the marketplaces, and brokers and agents that sell marketplace plans. There are some things, even though this says 2026, there were some things when I perused it really quickly that did seem to have 2025 dates on them. I've not read the whole thing, but the key things that they point out as being important components of the rule in the sort of fact sheet, that's the first link, are anti-fraud provisions, changes to the risk adjustment programs, and then public quality reporting requirements. So we will definitely take a closer look at that. You can find the rule itself at the second link and some information about it at the first. Any questions or comments or thoughts there? All right, let's keep going. HHS OIG has put out a report on maternal health parity in Medicaid. The report is actually, that's what they stress in the report, but it's actually more specifically on the state of maternal health coverage in Medicaid. And they look a lot at MCOs. And I pulled out some of the top line reporting they did in the report, which is that pretty much coverage for OBGYN providers and hospitals is almost universal, but covering other types of providers and care, some of which are federally required to be covered, is not. And so there's a gap there between what people are expected to cover and what is being covered in many cases. They also note that in many states, the network adequacy calculations and determinations do not split by specialties in ways that are conducive to tracking whether OBGYNs are adequate within the network. And they see that as a major problem. And then the other thing they point out under the network adequacy discussions are that when part of the network adequacy discussion is expected wait times for appointments within the rules, and there's an expectation that the wait times for appointments will vary at different, what's an allowable wait time for appointments varies depending on the stage of pregnancy a pregnant person is in. And not all the states use the tailored standards when looking at adjusting wait times. And then the other thing they say is that while they might technically follow the rules for monitoring network adequacy standards, a lot of it's at the surface level, and there's not really a consideration of what actual enrollees have to do to access care. So this is obviously just top line stuff. It's a fairly lengthy report. You can read the entire thing at the link. If you're interested in this topic, I suggest you do so, but I would suspect, I'm speculating here, that given what this report says, and within the context of possible administration changes, but even within that, I would think that it would be likely be a precursor to some rulemaking in this area. Just that would be my expectation if a report like this came out. So we'll keep an eye out for that. Anyone have any other comments or thoughts or questions about this? All right, let's keep going. So CMS has put out a little bit of a rah-rah letter, which, as someone who isn't super self-promotional, always strikes me the wrong way, but it's actually kind of useful if you want to take a look at what's going on in a very busy time. So they basically highlight various activities that have happened in the last 4 years, provide some interesting statistics about different programs and access to care, and it's kind of a handy way to get a quick overview of a lot of things in one place. So they split it into the 6 strategic pillars that come up in a lot of their planning documents. And within each of those, they have discussions of specific programs. So if you're interested in reminding yourself of some of the stuff that's happened in the last 4 years, or if you just need want to have a handy reference, if you need to check something and see, like a high level description of something, or if it happened, something you think happened recently, it may be handy to have around. But I'm not suggesting that you run out and read it. And like I said, I do find that type of self-promotional report a little bit strange, but I'm not a salesy person. So any comments or questions or thoughts there? All right, let's keep going. All right, so now this one's very interesting. Medicare has put out a report that takes a look at the acute hospital at home services that ramped up during the pandemic and are still allowed via exceptions to the rules, and compared it to what they're calling brick and mortar hospital care within the report in a variety of areas. And so one of the things that was pretty interesting was they looked at the demographics, and they looked at spending, and then they looked at patient experience. And then they also call out that because the program is ramped up under emergency conditions, it doesn't have the same level of controlled comparisons or sort of research and measurement around how it's performing as many of the other programs do. So one thing that I thought was interesting was this first point, that hospital home patients are more likely to be white and living in an urban area. But when you look at that a little bit closer, they set up the program where that almost has to be true, because there's a requirement that you be within 30 minutes of on-site care, even with, under the worst of circumstances. And that could be someone coming to you or you going somewhere. And you have to have what they consider psychosocial and home environments that are conducive to at-home care. That means having enough space, that means having enough money to have certain types of services. It probably means not being, anyone who's more disadvantaged probably has a harder time. What I'm trying to say is anyone who's either disadvantaged or has any type of special needs, or in some cases, just because of societal built-in equity issues, it's more likely for certain people of other races will have a harder time meeting those conditions as well. So I think that at the same time, a lot of those requirements are there for safety reasons. So it's not like well, those should be removed so that it's more equitable, because the requirements that put those in place are safety requirements. So it's an interesting conundrum with this program that it's more likely to help. But I would point out as well, not to go off on a tangent, but if it frees up resources, maybe what it's doing is freeing up resources in the hospitals themselves that allows better care, on-site care for those patients who aren't able to take care of to use the hospital at home report. I don't know if that's fully true or not, but I think that's an area worth researching. So I think this is an area that they're going to have to do a lot more. I don't want to use the term soul searching, but a lot more consideration as to where that balance is, because obviously you can't make choices that are going to be detrimental to safety. But at the same time, you want programs to be as equitable as possible. So I think that's the biggest takeaway from this report, personally. Another thing that was really interesting was that the spending per patient was not demonstrably lower for the hospital at home versus the on-site. One of the arguments that people had made for maintaining hospital at home was that it's cheaper. And at least as far as the Medicare payment portion goes, that is not true, not showing true, at least not within the confines of the way this particular program is structured. However, the people who've experienced the program were almost, pretty happy with it. And there are other advantages to it. So it was a very interesting report because it wasn't overwhelmingly positive or overwhelmingly negative. It pointed out a lot of pros, some cons, and kind of laid out, I think the upshot is, maybe what's needed is to rebuild the program in a way that has those controls and measurement criteria in mind, but keep it going with those built in better, so that you can get more accurate and useful data around determining how the program's performing. So I think those were kind of the key takeaways. I think it was a very interesting report. And if you want to read it, you can find it at that link. Anyone want to comment or question or challenge my thoughts on any of that?
One thing I would add, Janice, is just as recently as yesterday, one of the presidential candidates made the hospital at home for Medicare patients a big part of their platform. So this may change over the next 4 years, depending on how the elections pan out. But I think we're seeing investments in hospital at home programs happening predominantly in urban areas because that's where there are major academic medical centers that have the capital and the expertise to do this. But I think over time, as that becomes more sort of operational and understandable, and they develop practices that other providers can use, that this is a huge shift in healthcare, and I think it will continue to grow over the course of the next, 5 to 10 years.
Great, thanks, Denny. I had missed that comment from the candidate, and so that's an interesting development. Anyone else want to comment? All right, well, something to keep an eye on. Let's keep going. So CMS has also put out some new guidance on the application of early and periodic screening, diagnostic, and treatment requirements for Medicaid and CHIP. So these are the various, like, children must have this test in first grade and must be screened for that by the time they're 4 type type requirements. And so there's a lot of different pieces. And so the guidance itself is fairly lengthy. I did not read all of it. I skimmed it and looked at some of the takeaway areas. But one of the things they're trying to do, one of the main things they're trying to do is to really make sure that various types of special needs children are really their needs are met within these programs. And some of that is expanding the workforce so that people can take the extra time needed to do things properly for certain types of disabilities or other types of special needs where it takes longer to do the same things, and just promote awareness that there are kids that are going to need that type of special consideration, and that you aren't going to be able to do these tests the same way for every single person out there, but that doesn't mean that they shouldn't be done for every single person out there. So I thought this was interesting. You can find a press release about it at the first link, and then the actual guidance at the second. And I think it's a step in the right direction. Anyone want to comment or have any thoughts on that? All right, let's keep going. CMS has updated its administrative simplification FAQ. There are now 14 entries. They cover a variety of topics, mostly around how to complain about non-compliance and what happens to a complaint when it's made, and also how to use the asset testing tool to determine if you or someone else is in compliance. So you can find the FAQ there. It's a PDF file. And read more about this stuff there. Any questions, thoughts, or comments? All right, next slide. If you'll pause there for a moment. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. That email address is also on your screen.